I always want to say good morning class since this is a 7:30 class, but since you're watching this yourself, I'm doubting you're watching it very early in the morning. So I'll just start with greetings. So today we're talking about posture and body mechanics. So sit up straight while you're reading this or watching this. So our objectives, we're going to identify elements of proper posture in sitting and standing, display an understanding of proper posture and the importance in relation to muscle activity and movement. We're going to identify common postural faults, their causes, and corrective actions. Display an understanding of proper body mechanics for activities. So posture is relative alignment of various body segments to one another. Good posture decreases stress applied to the body segments. And our reference point of posture is static standing. So using a plumb line, you've probably used a plumb line in another class. I doubt that you used a nice little plumb line like you see here on the screen, but probably a jump rope, I'm guessing. So you see the pictures to the right. You see the example of good posture. Then to the left, you see the guy slouched forward, knees flexed, the kyphosis in his upper lumbar and his thoracic spine, and then his forward head. And then on the far right, you see now his knees are straight, but to compensate, he has extended his lower lumbar spine. Still has the forward head and still has the kyphosis in the thoracic spine. So looking at the anterior view, we should have feet equidistant from the plumb line. The arms are relaxed to the side. The palms should be facing towards the thighs. If you have somebody that's a bodybuilder type, that has a large chest, that overworks the chest, underworks the back, and that you may see that they have palms facing backwards due to the increased internal rotation at the humerus due to the pec tightness and the lats as well. So the plumb line should bisect the body into symmetrical sides, right and left. You should have level body segments at the malleolus, at the knee, at the pelvis. The shoulders, you won't always have a level alignment due to handedness. So you may have a shoulder that's down just a little bit more on the side that they're dominant on, especially with an overhead athlete, somebody that does the same thing over and over with the one side of their body. And then the feet should be fairly straight, maybe outward just a little bit. If you have somebody that's slew-footed or duck-footed and their feet turn out, may have a lot of external rotation tightness at their hip joints. Or you could have somebody that's more pigeon-toed where their toes point more inward. And then the backside view, again, you should be symmetrical side to side. You should have equal level at kind of the same areas, the popliteal space, the medial malleolus, the iliac crest. Again, you may have some differentiation at the scapula, may be a little bit off side to side due to handedness. And then our lateral view, so we see how it goes from the ear to the acromion to the greater trochanter of the hip, and then slightly anterior to the center of the knee, just behind the patella, and then it should go anterior to the lateral malleolus. And so in that position, everything is well distributed, the weight is equally distributed, the body is balanced, and there shouldn't be a lot of muscle activity helping to hold this person up in the standing position at this point. You should also see a lumbar, should have a curve inward or lordosis. You have a kyphosis at the thoracic spine and then another lordosis there at the cervical spine. You should have slight chin tucked. Your head should not be forward. The ear should be over the shoulder. And then in sitting, we see the same thing. We see the three curves of the spine. You have the head, the eyes level. So in this position, we want to have the spine perfectly aligned so that it equally distributes the forces of the spine. They've done studies where they took pressures to see how much force was being placed upon the lumbar spine in 3 different positions: in sitting, in supine, and in standing. And in sitting, you have the greatest amount of pressure in the lower back. Again, your pressure is now distributed just between the hips and the head, whereas with standing, you have your legs will dissipate a lot of that forces. And of course, in supine, gravity is not pulling axially through the skeleton or through the spine. So our feet should be on the floor. Our hips should be a little bit higher than the knees. If your knees are higher, then that puts you in a posterior pelvic tilt, which then decreases your lumbar lordosis and increases your thoracic kyphosis. So you don't want the edge of the seat to press on the back of the knees. The chair should help support the lumbar and thoracic spine. The arms should be at about 90 degrees at the elbow, and you should have good spinal alignment, again, to dissipate those forces. So looking at the lumbar area and the pelvis, so again, you should have a lordosis at your lumbar spine. If you're sway backed or you have an anterior pelvic tilt, you have excess lordosis. You can cause a degenerative disc disease, as it's going to wear those discs more quickly than with proper spinal alignment. Could get nerve root compression, especially in adolescent males. You might get a spondylolisthesis. On the other hand, if you have a posterior pelvic tilt or a flattening of the lordosis, you have the decreased ability of the lumbar spine to absorb forces. You want the back to share the load, so you don't want those forces to go just to the lower back and be absorbed there. So in this position also, you see the flatness of the thoracic spine and the cervical spine as well. So you lose all 3 curves in this position. This can again lead to degenerative disc disease, as it's abnormally wearing on the spine. You could also be setting yourself up for a compression fracture here, as your spine is more vertically loaded. You're getting a column of pressure, so it's less able to dissipate the forces. So I just mentioned spondylolisthesis. So you see the arrow pointing to the collar on the Scotty dog's neck, the head being above to the right, looking forward to the right, and the body down to the left below. And you see how that's L4-5, how L4 has slipped anterior in relationship to L5. And then you see how L3 and L2 are more vertically stacked now. So they're getting all their extension just off of that one point, which has caused a fracture of the pars. With these folks, we definitely want to avoid doing lumbar extension exercises, so we want to be more flexion biased with these people because we don't want to make that worse. And then let's talk about their thoracic spine. So we have a natural kyphosis or flexion or rounding of the upper back. But when we have excess, this is caused by chronic posture, so sacral sitting. This results in pec tightness and weakness in your rhomboids and your trapezius, as well as your erector spinae. And this is one thing that I've noticed during this past year with a lot of our athletes, how they don't have the ability to extend through their thoracic spine. So they've developed this kyphosis. They are unable to fully access the extension of the thoracic spine that they need. So where they're getting their extension is in the lumbar spine. So you have them actively extend their spine, and you'll see the only thing that's moving is in the lumbar spine and typically lower down. And so a lot of these people are coming in with back pain and problems because they have not been sharing the load, and the load has just been going down to the lower lumbar spine, and it's overworking that area, and that area is starting to break down and cause pain. So we're trying to get them to work more through their thoracic spine. And then the picture down to the right is a sign of scoliosis, or a picture of scoliosis. So you see that C shape of her lower thoracic and her lumbar spine. You'll also see kind of an S curve because now in compensation, the upper thoracic spine moves in the opposite direction, kind of giving it an S shape. But the primary problem is there at that curve, you see the C shape. So you on the concave side or the right side, you'll see she's going to develop tightness in her erector spinae or quadratus lumborum there. On the left side, she's going to get weakness as those muscles are chronically elongated. Scoliosis leads to vertebral rotation, and you'll see a telltale sign of the rib hump. You may remember back in elementary school, you would have scoliosis screenings where you had to take your shirt off, which terrified me as a kid, and bend forward. They're looking for that telltale sign of that hump. The hips will typically remain even or level, and this is typically a congenital deformity. It's not a postural issue, but it's something that we want to be mindful of and look for. You can get some scoliosis type things from leg length differences or long-term unilateral activities, but almost all of them that you're going to see are congenital in nature. So the postural assessment is really important to look at the position of the scapula. So the scapula normally rests on the posterior thoracic wall between T3 and T7. It's not a true joint at the where the scapulothoracic part of the joint is not a true joint, in that two bones are not articulating. So you've got muscle on each side that's actually moving. So you have some variance, basically due to handedness. You'll see some differences. You want the scapula to be in a good position because you want the glenoid fossa to face slightly upward and forward. In this position, it allows for clearance of the humeral head underneath the acromion. If it's pointing down and forward, then it's going to lead to impingement possibly. So now let's talk about the head and the cervical spine. So we want the ear over the acromion. The cervical spine aligns in relation to the lumbar and thoracic alignment because the eyes will set level. So if you have proper positioning of the lumbar spine, that'll bring your thoracic spine in line. And then because of the position of the head and keeping the eyes level, you will have better spinal alignment in the cervical spine. So poor posture will lead to cervical malalignment. So you see the guy on the far right of this picture, how far forward his head is. So now he has flexion at the lower cervical, and which has resulted in extension in the upper cervical spine as his eyes become right or level with the world. So over time, this individual is going to get where he cannot get into the position you see on the far left. Over time, this is going to create hypomobility in the cervical vertebrae, and he's not going to be able to bring his head up. You've probably seen people in this position. A lot of times they'll have a dowager's hump, and you can see that developing just to the left of the plumb line on that far right picture. And it's because of that chronic positioning, and those folks just aren't going to, once they're in that position, they've developed the muscle tightness, they've developed the joint hypomobility. There's not much fixing that, and that's going to also limit their cervical rotation as well as side bending. Can also have TMJ problems, headaches as well. So this is not a good position to be in. Upper body cross syndrome. So basically this means that you got weakness on one side and tightness on the opposite side. So agonists may be tight and the antagonists are weak, or the agonists are weak and the antagonists are tight. Hope I said that right. Anyway, the picture here shows the weakness in the deep neck flexors. with resultant tightness on the opposite side. So the upper traps and the levator scap are tight. And then you have tight pecs, and then you have weakness in the lower trap and the serratus anterior. So that's what we see from this chronic posturing is that you'll have weakness on one side, tightness on the other. And so with these folks, we want to strengthen one side and stretch the other. So we're going to stretch the pecs and the upper trap and the levator, and we're going to strengthen the deep neck flexors and the lower trap and the serratus. We also have a lower crossed body syndrome happening at the pelvis. So the same type of thing. Diagonally, you have tight lumbar extensors and tight iliopsoas and rectus femoris, and then you have weak abs and weak glutes. So again, if your abs are the agonist, they're weak. The antagonist are tight. The lumbar extensors or the hip extensors. No, check that. Not the hip extensors, the thoracolumbar extensors, because the weak glutes are the hip extensors. So you have weak. If your agonists are the glutes, you have weakness in the hip extension, and you're going to have tightness in the opposite side at the iliofemoris and the rectus femoris. Those are really important to be able to detect both the upper and lower cross syndromes, and to be able to not only detect them, but then to correct for them. Because if we have tightness and weakness, it's changing our length tension curves, and it's really placing our athletes at a position for injury. So let's talk about a lateral shift. A lateral shift is not scoliosis. So the guy to the right, you can see the C shape of his lumbar spine. This is not scoliosis. This is a temporary condition. And what happens is due to muscle spasm or impinged nerve root, this person will lean away trying to shift weight off of that impinged nerve. Typically more of the impinged nerve root rather than the muscle spasm. So the pelvis and the shoulder is not lying in the same frontal plane, and they're shifted right or left of midline. This is very correctable, and it's usually corrected fairly quickly, especially somebody with a nerve root impingement type of thing. So looking at lower extremities, so we can have genu valgus, in which the knees are angled in towards each other, and you can have weak quads. More likely, you got weak hip abductors and weak glutes. You can have excessive foot pronation. It can occur on one side, possibly from a leg length discrepancy. It can be also from osteoarthritis. So that's the knock-kneed condition. And then genu varis is the bow-legged condition. They typically have higher arches. You can have one-side occurrence, again, usually osteoarthritis. So you see the picture on the right, how this lady's right knee is really osteoarthritic, causing that genu valgus. And then the picture in the middle, the guy obviously has some genu varis, as he's very bow-legged. So my dad was real bow-legged and ended up having both of his knees replaced, and he grew about an inch taller whenever they lined his knees up properly. So poor posture is habitual. So we wonder, do muscle imbalances result in poor posture, or does poor posture result in muscular imbalances? So muscular imbalance is alteration of the length tension curve. So if an agonist, let's say the pectoralis, becomes shortened due to chronic posture, then the antagonist, or the scapular retractors, become elongated and unable to produce effective, efficient contraction. So that's what we're seeing with the upper cross syndrome. So did it begin with this person had weakness in the scapular retractors, which then made them sit with poor posture because those muscles just couldn't hold them upright? Or maybe we have somebody that did a lot of too much chest work and now their pecs have overworked and have overpowered the antagonist, the scapular retractors. Chicken and egg type of thing. We also will get joint changes, so we can have hypo or hypermobility. So again, like I was talking about earlier with some of our athletes having a loss of thoracic extension, so they become hypomobile in those segments, and as a result they become hypermobile in their lower lumbar segments. So what we got to do with those folks is we've got to mobilize them in the hypomobile sections. So we want to mobilize their thoracic spine, but we want to stabilize their hypermobile segments in their lumbar spine. So it's important that we do both. If we only do one and we miss the other one, then we're not going to have very effective rehabilitation. So then let's talk about body mechanics. That's the way the body is positioned and used during activity. Poor mechanics can result in excessive stress in the body or individual parts, decreased efficiency in strength, power, and energy conservation, and ultimately poor body mechanics may lead to injury. So some key principles to body mechanics is we want proper spinal alignment with abdominal bracing. We want a broadened base of support. Again, you're back to that first point. So we want our spine to be in proper alignment. We want it to share the load. And then our abs are our natural back brace. So we want to use our abs regardless of whether we're picking up a pencil or we're deadlifting 500 pounds. And then we want to broaden our base of support. We want to lower our center of gravity. We want to make sure we stand in the direction of force. So we don't want to twist. So if we're picking up something and setting it on a shelf, we don't want to pick it up and twist our body as we're going there. We want to stand in line with the shelf of where we're setting it. And then lastly, we want to keep the line of gravity within the base of support. And we got some video here that we're going to watch of proper lifting techniques. There we go. So we'll watch this video here of how this toddler squats. So you notice she has her center of gravity. She's reached within her base of support. And then she used her hips and knees to do all the motion. She didn't bend from her waist to pick up the object, which would be very easy for you and I to do. So again, watch the hip hinge here. So the knees bend, the buttocks drops back, get hinging off of the hips as she reaches. See a nice wide base of support. All right, that's today's lecture. Hope you enjoyed it. Bring your questions to class, and we'll look forward to seeing you in class and having a good lab.